Good afternoon, everyone. I'm Melanie with the Arizona Telemedicine Program and Southwest Telehealth Resource Center. And today I'm coming to you from Tucson. And of course, we have our speaker, Carol Yarbrough, who's coming to us from Washington, D.C. area today. So, at the University of Arizona, we respectfully acknowledge the University of Arizona is on the land and territories of indigenous peoples, and today Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents the states of Colorado, Arizona, New Mexico, Nevada, and the Four Corners regions, with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and indigenous communities through education offerings, partnerships, and community service. All right, so today, as you were logging in, so again, welcome everybody for our region, any other fellow HRSA grantees, and all of our participants today. So again, this is the Arizona Telemedicine Program, and this is a free webinar series. This one does not have CMEs. We need to fix that.
Yeah, I'll delete that.
No, no CMEs on this one because this is an office hours session. So we got people. Your questions that you put into your registration have been forwarded to Miss Yarbrough, so she will be addressing those that she can. All right, next slide. As you were connected today, your phone or your computer microphone were muted, but please use the chat function. Down on the bottom of your page, you'll see the little, like a little bubble window. Click on that and you'll get the chat window that will open up on the right side of your screen, and go ahead and put your questions in there. There's a post-webinar evaluation. Um, and yes, there's no CME again for this, but it is being recorded,
Sorry.
and the recording will be posted on the ATP website. Well, last time we had Carol, we did do a CME webinar, which is why we've got that in there. Anyway, so today's office hours, the 2025 MPFS, and all of you that are into the billing and reimbursements know what that means. So, without any further ado, I'm going to hand over the mic to Miss Yarbrough, who is our presenter for today. You know her well. Um, Yes, or stump the coder. I love that. The webinar will be recorded. The evaluation link will pop up behind your screen today, and I will also post it in the chat. So, Carol, go ahead and take it away.
Thank you for that kind introduction, and to the Southwest TRC and the Arizona Telemedicine Program. Very much indebted and grateful to have this opportunity to present ad nauseum with everyone who attends. So I just am really glad to share this information with you. Just so you know, I thought, since I was in Washington, D.C. today on a business trip, that I perhaps would not have any dog discourse, as you so often have been introduced to in my home in San Francisco. But this is Lucky, and he does like to bark. I'm in an Airbnb, and he's a lovely dog, and he may have opinions. But of course, the opinions I express are my own, and not Arizona Telemedicine, Southwest TRC, or any of the organizations I currently work for. Okay, I'm going to do an overview of why is Medicare telehealth like this, Social Security Act provisions and changes. I'm going to intersperse your pre-submitted Q&A throughout. You may recognize your questions, and then there will be a Q&A. We like this to be interactive, but I tend to wax on. So please feel free to interrupt me, because I just might go on too long and then you won't get your question answered. And I think I should first interject. Okay, let me get this slide out of the way. As always, things to consider while you're listening to what I'm saying. Of course, what type of clinic you work in, but what is said has different applications to different locations. What type of services do you provide? Again, it depends where you are providing services, and where and what, who, what, when, where, and how, and where's your geographic location. Okay, so I want to talk about what I heard this morning in a congressional panel. Congresswoman Matsui's office may or may not have let us know that the Energy and Commerce Committee may or may not have let us know that the Energy and Commerce Committee did release a possible 2-year extension for telehealth services starting January 1st. If we're lucky, it will remain the full 2 years. It's not a permanent solution as we're continue to hope for, but as we get ever closer to the end of the year, we are grateful that Congress has taken their beneficiaries' wishes into account in that they want to continue receiving telehealth no matter where they live, rural, urban, across this, across the street from where you would be HRSA eligible, and continue receiving many of the services. And I'm going to let you know, not all of the services are going to continue, but at least from what my understanding is, we will find out definitively by December 20th. So if you're watching a recording of this webinar past December 20th, please note that things are changing and hopefully change for the better for all of us. Whether it be, it's certainly not a 3-month extension, but certainly it's either a 1 or 2 year extension. So that's great. So why is telehealth like this? Why are we getting anxious at the end of every period of time where Congress has given us an extension? Well, it has to be Congress doing the extension and not CMS. If you've received any of CMS's recent or HRSA's recent email or newsletters, or they're saying, hey, an annual wellness visit via telehealth is a great way to complete this task. Hey, telehealth is great. And then, of course, on Medicare.gov, it's been alerting beneficiaries that the telehealth extensions will cease as of December 31st. So you may have been experiencing patients calling in saying, I understand I would like a telehealth visit, but my Medicare.gov site says that it's not continuing. And you've been saying, I don't know if it will or not. It's supposed to stop, but Congress might give us an extension. So we're still in that same boat, but it's like, I don't know, 70% sure something's going to happen, 75%. Anyway, and the why of it is Medicare doesn't get to tell us about where you can have a telehealth visit or who an eligible provider is, because that is statutorily hard-coded into the Social Security Act, which is, what gives us Medicare. And so that is the authority, the regulatory, statutory authority that then filters down to CMS, who provides us with the administration of that system and gives us the guidelines. So again, I'm providing this beautiful chart that I believe May Kwong or her staff put together because I love it so much. Okay. One of the first questions I got, can a pro fee be billed if the patient is not at eligible originating site? Well, no. But now I have to say it depends. So what are eligible originating sites according to the SSA? These sites, an office, a CAH, an RHC, FQ, hospital. And it does say the home of an individual only for the purposes of treatment of SUD or a co-occurring mental health disorder. The home for purposes of home dialysis. And it should also say the home for purposes of the mental health disorder, a mental health disorder. So that was not put into the communication that was sent out. But depending, so if the patient is not at an eligible originating site, no. But what is eligible remains to be seen. Currently, it's no, but maybe by December 20th, it'll be yes, the patient can be seen in their home in an urban area, um, regardless of the services they're receiving. And then here again is, so I looked up an FQ in Tucson, Arizona, and I input the address. You may recognize your own FQHC where you work. Here's the geocoded address. But when I put it into the HRSA eligibility locator tool, which you may recall from 2019 or thereabouts, before we had the public health emergency, this would let us know whether or not the originating site would qualify to allow the distance site provider to bill a telehealth visit. And then it would also allow the clinic to bill an originating site visit or an originating site fee. So Tucson is large. And so, yeah, no, it doesn't qualify this week. As of this week, on January 1st, it does not qualify. I'm going to take a quick look at the chat. Trouble hearing me. Oh, I'm so sorry. Am I louder now?
You,
I am. I'm.
you're plenty loud, Carol.
Oh,
Um,
okay.
I'm
Okay.
I can hear you fine, but yeah, if you're a little closer to the mic, it might help some folks
My
that are
looming
having a little trouble.
face. Okay. And
That works.
Lori, the slides are going to be up on the site. Thank you, Melanie. Okay. So always the slides are going to be available to you. I know they're beautiful. Okay. Question: can FQs and RHCs continue to use telehealth? Yes, through the end of 2025. Continue for even non-behavioral health visits that use telecommunication technology, allowing mental and non-mental health services. Continue to do this and also continue to code G2025. This is directly lifted from the Federal Register final rule. So that was in question before. Okay, places of service, I guess, as of 2025. I'm sorry, this is so nebulous, but I'm going to give you the and or answer for a lot of these. So places of service 02, that was our favorite, our original telehealth. Now it's telehealth provided other than in patient's home. So as of 2025, if Congress does not enact an extension, patient must be in an eligible originating site, one of those places on the prior slide, and geolocation. So you put the address of whatever facility type building into that HRSA geolocator, and it's going to tell you yes or no. So the provider, it can be anywhere. You put in the facility clinic on the 1500. It's just their usual place of business, because that's something that was extended this year. Even if the provider is providing telehealth services or video visit or audio only from their own home, CMS is only requiring the provider's usual place of business. So O2 is for a facility. It's pro fee only, really. So you get reimbursed as a provider the facility pro fee rate. And that patient at the originating site gets their service. And then the originating site gets to bill the Q3014 and get around $32, $31 this year. Same. So if the patient's at home and the person is practicing from a hospital outpatient department, you're not reimbursed. Check with legal if you want to submit the CPT with a GY modifier. You know, this is a practice that was adopted by Noridian prior to the pandemic. Depending on how many Medicare patients you currently have in the pipeline, check with your legal and risk management folks, with your attorney if you don't have those in-house. Make sure that you're billing correctly. Same thing. So 10, place of service 10, Now, this is what I heard from CMS last week in response to an email. Telehealth provided into in patient's home, behavioral health plus med management. So they did modify the Social Security Act to allow an E&M to take place in a patient's home as an originating site, not just behavioral health codes, but they did amend this SSA so that a psychiatrist could continue to prescribe. Thank you to the DEA for giving us one more year to be able to prescribe Schedule 2 through 5 drugs. They can continue to do so to a patient's home. And you don't have to worry about seen within 6 months of an in-person visit, or if it's been 12 months since the last in-person visit. That is extended for this year. It may be implemented in 2026. That caveat was codified and is in the Social Security Act. I did hear today they're trying to get that backed out. Congress, they. So anyway, either or, even if you're at a facility, I was told, and hopefully we'll get some more guidance out on this, because this was in response to the open door forum that we had about the MPFS with CMS. We will all get the non-facility rate, a non-facility clinic and a facility clinic. I think they want to incentivize behavioral health providers to continue seeing patients in their homes, given the breadth of the mental health crisis brought on by the substance use disorder crisis, the opioid crisis. Mental health is certainly something that needs to be continued. So to incentivize, everyone's getting paid the non-facility rate, which means the global fee that you would get paid as if you were in a place of service 11. Okay. If someone's providing a medicine visit only, meaning nothing to do with 908, a 99215 only, perhaps, if you are a cardiologist, you put your provider location, and then currently, as of January 1st, that would not be reimbursed. So we'll see what happens. Guess I'll have to come back and update everything. Okay, so here's the revision I was talking about a little bit. So they did revise the Social Security Act to include audio only. And this is why the E&M code is important, because it does say that as a provider, you have to be able to use audio only and or video. So you have to be capable of doing it all. The provider, it has to have all of that, but the patient, either they can't, they don't want to, whatever, they get to choose how they want to receive their care for audio only. And so then if you're calling from a non-facility, that's modifier 93, which means audio only, or FQ, which also means audio only. FQHCs and RHCs are, however, required to use FQ modifier. So if you're anywhere else, you can use 93, you can use FQ, but if you're at an FQ, that's a good mnemonic, use the FQ modifier. So that's why it's important that they changed this so that if you need to prescribe something, that means you are providing an evaluation and management prescriptive type of activity as a behavioral health provider. Maybe I do a half-hour therapy session, and then maybe I'm going to prescribe something else for anxiety, but to prescribe, it's an evaluation and management service, perhaps, if it's for a different condition. And so then you put a 93 on the E&M code. Now, I put this into ChatGPT because I'm hoping everyone is as lazy as I am now. Like, here's the rule, ChatGPT. Can I please have a statement that says I have met all the requirements of an audio only visit as a provider? and it gave me a really long one. And then I put it back into ChatGPT and I said, can you make this simpler and shorter? This was the short version. I'm sure you can take this, put it into ChatGPT and try to get a shorter one. I'm sure you can. But it does meet all of the requirements. Audio only, even though I've got audio, video, patient didn't want to, broadband didn't reach, something broke, camera broke on the computer, patient was informed, they consented to keep going because that consent has to be obtained. And then a brief overview of what took place during that encounter. Same old, same old. So I'm going to just check the chat. FQHC and RHCs, what if they are located in a metropolitan statistical area? Can they continue telehealth? No. No, they have to meet the geographic and because remember, FQHCs and RHCs could not be distant site providers prior to the PHE. So they can continue to be distant site providers, but they also have to meet the geographic requirements. Okay, medical and mental. Yes, Nancy and Bob. Patient still has to be at a qualifying originating site. I think the patient can be at home. No, you're right. They can't. They can't be at home. They've got to be somewhere great in a building that qualifies as a facility. Because remember Hospital Without Walls that was in effect through 2022? That ended. We should not have been able to bill from a facility as a facility provider after that, but CMS gave us a waiver. So collectively, us. All right. That ends. I'm going to talk about that in a second. Somebody asked about, will CMS continue to pay at parity? Yes. Parity according to how you're usually reimbursed. So if you're doing behavioral health to a patient's home, place of service 10, and it's behavioral health either from a non-facility or a facility, you get the global payment. It's my understanding. I did confirm it in writing. It might change. It won't feel like parity because the conversion factor was decreased by 2.8%. Here's some examples of what a dollar less means for a practice. I'm going to go back. Note that there is a bill pending with Congress to raise the conversion factor by 1.8%. So you'd get 60 cents more per RVU. So instead of $70.22, you'd get $70.82. So that's 30. Okay, I can't add. $32.96 per RVU. So I hope that rate goes in, the adjusted rate. And recall last year it had been $32 for 3 months, and then they increased it in March. Congress. So this could happen again. We don't know. All right, so I mentioned earlier, the in-person visit requirement has been postponed for the year of 2025. Again, this is in the Federal Register final rule again. Behavioral health provider must be seen with, you have to see somebody in person, and then you have to complete that video visit within 6 months. Maybe your appearance changes in 7 months and they don't recognize you on the encounter. And then that's going to go out to a year after annually. And then it also says Secretary of Health will determine subsequent intervals. Remains to be seen. This includes RHCs and FQs. So everyone's off the hook for 6 months. The 6-month requirement, not for the duration of. Okay. Another good thing that we discussed when we had our webinar on the proposed fee schedule, this remained in place. No frequency limitations. Recall prior to the pandemic, you could only see patients inpatient via telehealth once every 3 days. Subsequent nursing facility visits, I believe, was also once every 3 days. Critical care consults, you can consult every day that patient is admitted if they need you, and there's criticality. And of course, new patient visits can be done because those codes are on the Medicare telehealth services list. Oh, and let me say something about that list. If it's on the list, it's Medicare telehealth. Then you use an O2 or a 10. If it's not on the list, it's not telehealth. I always think of that Memorex commercial. If it ain't live, if you can't tell if it's live or not, that's Memorex. Okay. There are, again, we mentioned this 6 months ago as well. We have a couple of new permanent codes, the Medicare telehealth services list, permanent, which is great. There's one code to be used by a physician or QHP, which means an advanced practice provider, APP, nurse practitioner, physician assistant, those types of people. Individual counseling for a person for pre-exposure prophylaxis. And then there's the G0013 for pre-exposure by clinical staff. And of course, this is an incident 2 type of service. So it must be, if you're in a non-facility clinic, it gets billed by no, it's just going to be a G0013. And then at the facility, that goes in on the UB04 as a facility service. It's all good. All right, supervision. This has been changed permanently for certain incident 2 services. I had to read this a couple of times because of the syntax of the sentence. So immediate availability means you have to be available as a supervisor. You have to be available via live video. You don't have to be there on live video the entire time. You have to be available via live video, immediately available. Like you're in the next room, you're on the video, not present yet available. So for a service that is tech only, when there is a modifier 26 or TC split that you see on the fee schedule, something that has a TC modifier can always be done under immediate availability. That means 99211, perhaps at a facility, and other things. Quite specific, aren't I? Or other things. And again, teaching physicians, residents, we mentioned that this was a possibility, and now it is in fact true. It's not changed permanently, but it's still on the books for 2025 that in order to teach a resident how to use telehealth, the teaching physician cannot be standing or sitting next to the resident. Everybody's got to be at their own computer. Patient, teaching physician, the resident, preferably 3 different locations. Didn't say geographic location, doesn't say a different address. I guess you could be in the next clinic room or office. Anyway, everyone's at their own station. but the supervision can still be done. This also still applies to the primary care exception during the first 6 months. So, list additions. This took me a little bit of reading as well. This is a demonstration addition. So this is very specific. Face-to-face demonstration of use of an INR monitor. So they're going to see, and it's a demonstration of whether or not it's going to be forever. And it's also a demonstration of how to use that INR monitor. So you have to have mechanical heart valve, chronic AF, venous thromboembolism. I'm going to uncross my legs so I don't get a DVT while I'm sitting here. Obtaining at least one blood sample. So you're going to show somebody via telehealth how to do their own blood work, evidently. Okay. So that's temporary. That's a G code. Okay. And the caregiver training services comparison, I did because I didn't understand it. So I had to map it out. So these are temporary. This is a temporary addition. I heartily believe that this is going to be a permanent addition. Caregiver training services generalized, as I put it. That's not the definition. It's just in general. Like, oh, so you're going to be, you know, the person you live with has dementia, you know, just in general, these are some safety tips that you can do. This is how you can speak with them. The difference between the 97550, 51, and 52 is that GCT D1, D2, and D3 are about specific targeted training. You have a decubitus ulcer that you're going to be changing the wound dressings on. Lucky to be doing that. This is a direct training. I believe the RVUs you're going to receive or the payment are going to be the same exact payment you get for those caregiver training services. I would hope a little bit more, not quite sure. Because if you're going to be changing dressings or maybe, gosh, I don't know what else. Just a very specific thing. Ulcers, I just can't think of an example. You can toss them into the chat to help my tired brain. So this is a temporary addition as well. I hope this stays on forever and ever. Group caregiver training and behavior management. Again, I'm going to change my behavior and how I respond to my co-inhabitant of where I live, my spouse, my child, my grandfather, my father, whomever. I'm going to change my behavior in response to their condition. So this is group caregiver training. CMS went one further to give individual caregiver training. When your dementia partner says XYZ, you can respond thusly. Type of activities. I love this. It should always be on the telehealth services list, CMS. Okay, so here's where we start getting confusing information. I'm crossing over to the outpatient prospective payment service final rule that was also issued on November 6th or 7th. Virtual direct supervision of cardiac rehab, intensive cardiac rehab, and pulmonary rehab will continue through the end of 2025. Now, recall that a nurse practitioner was given direct supervision capabilities in 2024. So an MD or an NP has to have direct supervision, has to have eyes on the prize type of oversight, perhaps into an exercise lab where a cardiac rehab technician is having a patient go through, treadmill test with ECGs attached, or treadmill with no ECGs, that type of thing. And that's going to last for another year. That's great. I think they're trying it out for size. Now check the chat. Oh, thanks, Kim. Functional performance, self-care. Yes. Oh, I see. So there's helping a caregiver to facilitate a patient putting their own socks on, whereas if the G code is training the caregiver to put the patient's socks on. Okay, thank you. Appreciate it. And then I have a question about G2211, billable with telehealth visits. It's showing, so what G2211 does is show longitudinal care. And is it on the list? I have to check. Now there was a change with 2211. I'm just going to respond to Nancy really quick. There's a change that and I'll get back to you about that question later, and we'll do a Q&A update. If the 2211, currently, if the E&M code has a modifier 25 on it, and because you've also done a venipuncture in that same visit, prior to next year, you couldn't bill G2211. Said anything with modifier 25, don't do it. Now you can. Bonus. Okay. And thank you, Nancy and Kim, for asking those or clarifying. Okay, so I was all excited 6 months ago that G0463 might be approved for facilities, hospital outpatient departments, to build the equivalent evaluation and management code, G code, that would cover the cost of doing business for facilities. What the decision, I believe, was predicated upon with reading this now is that there were the 17 evaluation and management telehealth codes adopted by the AMA, published in the CPT book. They deleted, recall, 99441 through 43, starting January 1st. They had equivalent codes for audio, video, and then audio only. So CMS said, we already got those codes. And plus, they're letting medication management and medical management be billed with a modifier 93. So why add on some even more stuff? But I think the comments they were looking for were directed like, well, if we adopt those 17 E&M telehealth codes, are we going to adopt a facility payment too? I got all excited. I thought if I build a 02 place of service, I would maybe perhaps get the option of billing a G0463, maybe with a, a revenue code 780 for telehealth. No, not so. Denied. I have a caveat for this too. I don't think I mentioned it later. Recall that PTs, okay, so for hospital-based clinics, it's either hospital outpatient department or physician-based hospital outpatient department, PBD or HOPD. Hospitals employ PTs, OTs, SLPs to provide those services to their inpatients and to their outpatients. Because of hospital without walls, outpatient departments were eligible to provide those services to patients in their homes. Without Hospital Without Walls, the conditions of participation are reinstated. And for a hospital employee to provide outpatient services to your home would have to qualify to be a non-facility or some type of clinic. They have to meet cleanliness guidelines, be licensed, da da da. So the confusion that is reigning right now is why are RD, and this includes RDs, this includes DSMNT and DMT. Why are those codes still on the Medicare telehealth services list? Why? Because if you work at a non-facility clinic, you can bill under your own NPI as one of those providers. You can bill directly for your service to a patient's home because it's a professional fee. It's not a hospital requirement that that home is a clinic. With the caveat that Congress, by December 20th, is going to grant professional fee services to continue to occur at a patient's home. This is what splits it out. Good times. Home health. Now these are put in as payment indicators for home health plans of care. Someone had asked if we can still do telehealth to a patient's home if they're in a home health program. Sure. And you can do RPM too. What you have to do is build it into your care plan, still using in-person care, in-person physiological data, blood pressure, temperature. But these are codes that you put on your charge report to indicate what was done or not done via telehealth or virtually, such as RPM is virtual care. It is not telehealth. It's not on the list. These aren't on the list either. So it's got to be in the plan of care. Fee schedule assigns a code status X. They don't have any RVU value, but you report it on your charge report when you submit your monthly bill for home health to show what was done. All right, I'm getting back again to those AMA telehealth codes. Everyone's wondering, what are commercials going to do about those 17 new codes? I don't know. I know for a fact that Medi-Cal is not adopting those codes. They have a modifier 93. Medicare 93, RHCs, FQHCs, FQ. So it's the modifier. So that the Appropriations Act of 2023 allowed these services via telephone. Remember, before 2020, they were in the CPT book and on the fee schedule, but they were bundled. They unbundled them, bundled because if you consider a day or two preceding a clinic visit, a day or two after, there's going to be telephone calls. This was unbundled to allow audio only care when we were in lockdown. It continued through the end of this year. While people are getting used to going back into a clinic, or they continued having video visits. Recall also on the Medicare telehealth services list, these codes were listed, so you had to bill them with I guess in 93, that's kind of crazy. If there was a telehealth list, that would be, well, 93. But there are audio only codes on that list. And you use a 93 modifier or an FQ. So telephone, oh, and I think I have on the next slide, I do, what a memory. Of those 17 codes that are for audio, video, and audio only that the AMA issued, only one code was adopted or adapted. This is updating the G 2012, which is the virtual check-in, pays a big whoopee $10 instead of the nice time-based chunk of change you would get for an audio-only E&M visit. This is a check-in, technology-based. It could be audio, it could be video. It's a virtual check-in. It is not typing. It is not an e-visit. It is synchronous. Has to be an established patient. Can't be a follow-up question from a visit that happened in the last 7 days. Hey, doc, can you call me back? Can I take aspirin before I have that procedure? No, can't bill for it. Can't be like, oh, your A1C is blah, 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 or I need you to do this. No. It's you're checking in. Hey, doc, I have this. Do I need to come in? Blah, blah, blah. And the doctor says, don't come in. $10. This is to at least start paying providers for the care they're giving when people call them unprovoked or uninitiated by the provider. It's got to be initiated by the patient. I'm calling, you're calling back saying, what's going on? Kaylee DeFore, audio only visits for medical. Reading this on CCHP, was my understanding behavioral health service and certain other are reimbursable if done via audio only modality. Can you make clarifying statement about audio only services? In general, will this no longer be reimbursable? If you're billing these services to a patient's home, for home dialysis, it was my belief that these cannot be done via audio only based on the Federal Register. I'm not sure. It does have to be a medical management type of activity. I have to get back to you on that one. I was thinking for ESRD, they also want a visual on what's going on. I'm just not sure. Table that for later. Okay. Digital devices, 249. We're doing great. Digital mental health treatment devices. I talked about this a lot. So you're going to use these codes instead of the remote therapeutic monitoring codes. I've heard stories that RTM, when used by a therapist to do cognitive behavioral therapy, they're not getting paid as an LCSW or a psychologist. They're paying for the 98978, which is for the software's medical device, the device code. They're not getting paid for the management codes. The answer to that are these 3 new codes. They're saying they're carrier priced. My suggestion would be to base on the current codes for RTM, remote therapeutic monitoring. So for a 98975, the equivalent, well, they're bagging a code. They got rid of the 98978. So this is like maybe you want to add $20 plus the 98978 reimbursement. So that would be $70 you'd get for this code. But you get to make that argument. Submit your billing to Noridian. They'll send it back. they'll say, well, I don't have a pricing for this yet. This is carrier priced. Can you please suggest to me what you think these codes are worth? And then they'll eventually establish that carrier pricing. I did warn you about my vacation dog barking. So this is great. This is going to make sure that as a behavioral therapist or behavioral health caregiver or provider, that you'll be able to bill these digital codes. Okay, behavioral health e-consults, again, super great. You can do all that work asynchronous now. Instead of, put in your full day of clinic work, and then a PCP is going to send you an e-consult saying, my patient has XYZ. Can you please advise me on CBT or whatever therapy that is not medication based? So this is the first e-consult code set that is not required to be ordered or provided, or not ordered, but provided by an MD or an NP, by an MD. Not even nurse practitioners can do an e-consult. Travesty. Innovation Center. Okay. I was looking at the physician fee schedule, and I noticed I was looking for the RTM codes to advise on that prior slide about the other codes. I typed in remote, and then these remote E&M visit codes came up, and I was like, oh no, what are these? Okay. They're nothing unless you are enrolled in the bundled payment something innovation. It's a bundled payment, BPCI advanced, and then CMMI, uh, uh, Center for Medicare and Medicaid Innovation. So CMMI home visit set, and then there's a BPCI home visit set. They had different years of inception. BPCI started in 2018. It was supposed to cease in 2024, but there was a 2-year extension. The CMMI visits, I'm not sure, but these are if you as a provider or a health system have enrolled for these bundled payments. And what they're doing is they're going to apply a normal E&M code reimbursement on this. So if you're submitting for payment at the end of this, the term of this patient's annual care plan or annual care, and while you report these codes and you get the dollar value ascribed to them by an E&M code, you might have provided more care than you get paid, type of thing. So they're pseudo codes. What am I saying? It's just a pseudo code. Okay. Considerations in our last couple of minutes. I know I was gonna ask if you had more questions, but we'll get there. Just consider for next year, this year. Okay, RPM. Someone asked, what's going on with RPM? I heard it changed. Well, okay, so RPM for a non-facility or facility, it's still 16 plus days required to bill these two codes. In 2016, there are going to be a whole new set of codes released, as well as changing the descriptor for 99457 and 58. New codes that are only going to require 2 to 15 days to bill. Also means less reimbursement, but that's okay. New for 2025, if you're an FQHC and RHC, remember like in the CCHP reimbursement guide, it said, you cannot do RPM. Well, this last year they said, well, if you're doing any care management, use G0511. Any care management. So chronic care management, principal care management, remote physiologic monitoring codes. So, which is a care management code because it starts with a 99. So I think it was confusing. People are like, do I bill one G0511 for 99453 or is it G0511 for the whole thing? So now they're saying use the RPM codes, use the chronic care management codes, use all the codes. No longer use G0511. Here's the new RPM service codes and what's going to happen when they come up with them. Sounds like telehealth, but it's not. It's chiffon. Okay, transitional care management. Someone had asked if that was telehealth. It's not, but it does have virtual elements. It does have audio only an element. You call someone within 2 days of discharge, and if it's not so urgent, you schedule a visit within 14 days. If it's more critical, call within 2 days of discharge. It's going to require a high level of medical decision making. Someone got a heart transplant. Someone had an appendix out. I don't know. That's pretty drastic. You're going to be seen within 7 calendar days. I bet you're going to see the next day after you're discharged. With that, collaborative care management. Gosh, this is a really hard management system to me. The question was posed, why isn't audio only allowed? I think that it has audio only elements. There is an initiating E&M that is done, that is audio video or in person. We'd have to, if you're really interested in billing the 99 or the initiating care E&M code via audio only, we'd have to ask Meridian. Of course, and here's I looked at the behavioral health services manual. This was specifically to access. I couldn't find anything that said audio only is not encouraged. Lori asked, does 98016 apply to an FQHC? I'm going to say yes, because it's an evaluation and management code. It's a virtual, well, not really. I mean, it's a virtual check-in. Gosh. Okay, my first inclination is to say yes, but my caution says, let me look it up. Okay. Any further questions? I'm happy to stay on the line. Here are all of your resources, everything and more. But if anyone would like to stay a little bit later, I am more than happy to answer anything right now. Just let me know. And if not, I thank you for your attention and your forbearance, and I wish you a very happy new year.
Thank you very much, Carol. As you were, of course, doing your presentation, you were watching the chat and answering the questions as we were going along. I'm going to go ahead and just put the previous webinar URL in the chat. Carol's slides and this recording will be available a little bit later today once it gets done processing.
Fantastic. Thank you.
So let's see here. There's one question that was right before my,
Okay.
can you see it? Right above where my,
Oh, you know what? SLPs and audiologists, the codes are still, they're not eligible providers. An SLP and an audiologist is not an eligible provider. We won't know until 12/20 really what's going to happen with that. I can tell you, if your folks are in a hospital outpatient department, done. But if they practice out of a non-facility, we'll find out.
So that specific question was, can SLPs and audiologists expect an update come 10/20, I'm sorry, coming 12/20, December 20th? As of now, their telehealth services will be discontinued. Yeah,
Yeah,
that's unfortunate.
it is. It is. Of course, I guess you can always take cash pay.
Well, yeah.
Not great for a Medicare beneficiary.
No, it's not. All
Well,
right.
thank
Thank you again, Carol, for
you.
your perspective and continue enjoying your CTEL attendee out there in DC area. Thank you for taking the time to present for us during that work trip you've got going on. And thank you, everybody, for joining us. Please keep checking out our website for future upcoming sessions. I'll send out a thank you email with this information and the links that I put into the chat as well. Again, thank you for attending. Everybody have a happy rest of the holiday, rest of this year, and we'll see you next year.
All right. Take care, all.
Thank you very much, Carol, and thanks everyone for joining us. We'll see you next time. Bye bye.
Bye-bye.